thank you everybody for being here today, and thank you to the Coalition for the invitation to speak. So I'm an emergency medicine physician and a medical toxicologist by training. And so because of that training, I've been interacting with patients with substance use disorders for most of the past 8 years. And it wasn't until near the end of my fellowship that I really began to feel comfortable talking with patients about their substance use disorders and talking about available treatment options. So it was this repeated and constant exposure to these patients that really enabled me to start talking about addiction and help me better understand the treatments, the best treatments available. So I now run an addiction medicine clinic through UPMC Pinnacle, in addition to working as an emergency physician and a medical toxicologist. So some perspective. So emergency medicine is defined as a specialty, medical specialty, dedicated to the diagnosis and treatment of unforeseen illness or injury. So our primary job is to resuscitate and stabilize patients, treat acute and life-threatening issues, and then refer patients to the appropriate departments or discharge them for follow-up. So I think it should come as no surprise that emergency physicians, like many other physicians, seem to be uncomfortable talking with patients about their addiction. It is just simply not a key component of our training. In addition, we often don't have time in the busy emergency department to effectively assess and manage these complex patients. So as some degree of anecdotal evidence, let me share this. I'm a member of a Facebook group called EM Docs, which you have to be an ER doctor to join, and it has 15,000 members. And people post interesting questions and cases and ask questions of other members. And many posts get hundreds of comments. And so this week, I asked the group of 15,000 people, what is their approach to patients with opioid use disorder? How comfortable do you feel talking to patients about their addiction? And I asked if they felt comfortable referring patients to treatment resources after discharge. I got 7 comments, 3 of them from personal friends. So having worked in multiple emergency departments in different states over the past 8 years, I've observed 2 typical approaches to patients with opioid use disorder. And since a significant number of these patients present to the ER after an acute overdose, the first approach is easy to accomplish. This addresses acute medical issues, if any exist, and avoids the underlying problem of opioid use disorder entirely. In other words, the physician ensures the patient is breathing and admits them to the hospital, or after a period of observation, discharges the patient home. The second approach is advising the patient to, quote, get off drugs, and providing a phone number, which may, but generally does not provide timely access to addiction treatment. The first approach, ignoring the problem, obviously results in the ongoing abuse of opioids. Many physicians and providers don't realize that the second approach may actually be associated with higher risk, including increased mortality. So while counterintuitive, if a patient with opioid use disorder takes the ED physician's advice and attempts unsupervised detoxification without medical assistance, the so-called cold turkey approach, they will begin to develop severe anxiety, depressed mood, and all of the annoying and very uncomfortable feelings of physiologic opioid withdrawal. These symptoms often occur away from their typical social environment of use with their fellow users, and results in them being isolated, feeling physically sick, emotionally unwell, while they are trying to kick it. As they cut down or stop their use, their physiologic tolerance for opioids declines. Not surprisingly, the social isolation, psychological desperation, and physical suffering often combine to form a triad that many patients cannot withstand, and they relapse, but they overshoot their declining opioid tolerance, and it results in overdose and/or death. So many emergency physicians are just simply uncomfortable with and unprepared to talk with patients about their substance use. So in addition to this, there exists, I believe, an incorrect belief about emergency departments' role in this epidemic. Some of this has been alluded to already, but until recently, public health policy responses to the opioid epidemic have focused largely on the emergency department's role as a pipeline for opioid prescriptions. This focus still persists and has been adopted by governmental and hospital administrators, in spite of data showing that emergency departments are responsible for as little as 5% of all opioid pain relievers in most communities. While we may account for 5 to 20% of total opioid prescriptions, emergency medicine physicians tend to prescribe small pill counts of low strength, immediate release opioids, so no long-acting OxyContin, which was referred to earlier. And so the actual contribution of opioid morphine equivalent is quite low. In fact, in one study of patients who died of prescription drug abuse, it was found that ED prescriptions accounted for only 1.5% of the pills prescribed to the decedents in the 12 months before their death. The take-home message is that although patients who subsequently die from opioid use disorder frequently present to the ED, they are receiving most of their pills elsewhere. And I believe it is important to point out, probably partially to defend my own specialty of emergency medicine, that much of the blame for this opioid epidemic lies elsewhere. Purdue Pharmaceuticals, the manufacturer of OxyContin, mounted an aggressive marketing campaign that included a warning from the FDA over misleading advertisements. The American Pain Society introduced pain as the fifth vital sign, making it the first and only subjective vital sign. The Joint Commission joined in 2001 and began issuing standards requiring the use of a pain scale and stressing the safety of opioids. Press Ganey deserves some blame with their emphasis on patient satisfaction, although at least one study out of California suggested higher patient satisfaction leads to higher rates of hospitalization and a higher risk of death. CMS, which is the Center for Medicare and Medicaid Services, developed a value-based purchasing program to shift from pay for volume to pay for value. Unfortunately, this value included patient satisfaction with their pain control. This effectively tied reimbursement to patient satisfaction and pain control. And you don't need to guess what happened next because we're here today because of it. I say all of that not primarily to deflect blame away from emergency medicine, but to help you understand a little bit more about how we got here. Human behavior is predictable enough to know that if your reimbursements and thus salaries are directly or indirectly tied to pain control, the overprescribing of opioids will become inevitable. So what I want to do today is propose to you that we should change how we view emergency departments in light of this epidemic. Emergency departments deal with all types of medical problems and social ills, and the most common reason that patients come to the emergency department is for some type of pain. We routinely deal with doctor shopping, drug seeking, and malingering, and approximately 1,700 people, according to the CDC, visit U.S. emergency departments daily with an opioid-related diagnosis. And this number continues to climb. So rather than viewing the prescribing patterns of emergency departments as the problem, and rather than viewing the doctor shopping, drug seeking, and malingering as problems that divert resources away from true emergencies, I propose that we instead view the emergency department as a golden opportunity to engage high-risk patients at a vulnerable time in the cycle of addiction. David Kahn, president-elect of the California Society of Addiction Medicine, says this: "The emergency department is a healthcare setting in which patients with opioid use disorders commonly present, seeking more opioids to maintain their addiction, seeking help with opioid withdrawal, or in some tragic instances, needing emergency resuscitation for opioid overdose. Emergency physicians are thus uniquely positioned to intervene to help patients with opioid use disorders at a critical moment in the addiction cycle." If that is true, and I think it is, the intervention will require a multidisciplinary approach. And though the notion of using the emergency department to propel someone into treatment and recovery remains a pipe dream for much of the nation, it can happen, and it's happening here. Many times, emergency department patients with the need for non-urgent follow-up are provided with the names, addresses, and phone numbers of the specialists they should see after discharge. Many patients never get an appointment. In a study published in the American Journal of Managed Care in 2007, 1,235 patients who had visited an ED with a diagnosis of substance use disorder were given follow-up. 13% received follow-up for substance services for substance use disorder within 14 days of their ED visit. One such way that emergency physicians can intervene in the cycle of addiction is the so-called warm handoff. And I'm sure many of you have heard about the warm handoff in the news. But in the warm handoff program, when a patient presents to the emergency department either after an overdose or seeking treatment for opioid use disorder, a substance abuse specialist or perhaps a medical toxicologist or an addiction medicine physician is called, and the patient is evaluated directly and relatively quickly in the ER. So after this initial evaluation and screen, the patient may either be transferred directly to inpatient treatment, or they may be discharged home with close contact maintained with the counselor and outpatient follow-up assured through this relationship. This treatment option has been referred to as SBIRT, or screening, brief intervention, and referral to treatment. There's a second possible option that was developed by Dr. D'Onofrio and colleagues from Yale and published in JAMA in 2015. This was a groundbreaking study. In 2009, Dr. D'Onofrio, an emergency physician with an interest in addiction, together with her staff at Yale, developed a groundbreaking program that screened ED patients for opioid use disorder and then initiated treatment with buprenorphine in the emergency department. Their study's stunning results demonstrated significantly increased engagement in addiction treatment, reduced self-reported illicit opioid use, and decreased use of inpatient addiction treatment services in patients who received buprenorphine while in the ED versus patients who received brief intervention and referral alone. This work is truly groundbreaking and strongly suggests that the ED initiation of treatment with buprenorphine is safe, feasible, and effective. I personally have done this in the emergency departments that I work in, and patients are receptive, appreciative, and most importantly, still in treatment. There are hospital and federal restrictions on buprenorphine that are not the focus of this talk, but be aware that this does result in some restriction of buprenorphine even within the ED or the hospital. So there's solid clinical evidence that shows that opioid substitution treatment, as we've already talked about, primarily with methadone and buprenorphine, is effective across a wide range of outcomes, including reducing all-cause mortality, improving physical and mental health, and decreasing illicit drug use, criminal activity, and risk of HIV infection. Emergency departments often find themselves on the front line of epidemics and natural disasters, and often against the odds, emergency physicians find a way to do what's right for the patient in front of them. My hope is that this current epidemic and situation we find ourselves in is no different. The emergency department can and should be used as a catalyst to bring together the patient with opioid use disorder with a treatment that has been shown time and again to be life-changing and life-saving.